So it's my privilege to invite Dr. Shivangi Kothari, Professor of Gastroenterology from Rochester, USA. Dr. Shivangi Kothari, Professor of Gastroenterology from Rochester, USA. Dr. Kothari is an Assistant Professor of Medicine and Associate Director of Endoscopy. She did her medical degree from Mumbai and completed intervention endoscopy training at Stanford University of Hospital, USA. And Dr. Kothari has clinical expertise in interventional EUS, advanced therapeutic ERCP, esophageal endotherapy for Barrett's esophagus, double balloon enteroscopy, and pancreatobiliary disorders. Dr. Kothari's interest in academic medicine had led her to practice evidence-based medicine and conducting multiple research projects. Her research interests include development of EUS FNA techniques, endoscopic ablation and therapy of Barrett's esophagus, and evaluation of new devices and technology in the diagnosis and treatment of biliary and pancreatic diseases. So without much ado, I'll hand over the mic to Dr. Shivangi Kothari.
Good afternoon, everyone. I'm Shivangi Kothari from University of Rochester in New York. I would like to thank Dr. Shastri and the entire planning committee for inviting me to give this talk, which is very close to my heart and something that is a big part of my clinical and research focus. I will be talking about assessment and resection, wide field resection of a large colonic polyp. You just heard Dr. Holt give a wonderful talk on cold snare resection, and I will be focusing on hot snare piecemeal resections of large colonic lesions, some successful resection do's and don'ts, and steps that are involved for a wide field endoscopic mucosal resection. If you look at the society guidelines, and with more and more literature coming out for cold snare resection of bigger and bigger polyps, the larger lesions greater than 10 millimeters and even those greater than 20 millimeters can be removed with hot snare polypectomy and piecemeal resections. And of course, lesions that have superficial invasion, then you can consider endoscopic submucosal dissection for those lesions. So before you plan resection of any large colonic polypoid lesion, perform a good visual inspection and evaluate for any appearance suggestive of a submucosal invasion based on morphology. The Paris type 2A or the laterally spreading tumors can further be classified into the granular and non-granular type lesions. Lesions with central depression have a high risk of malignancy, and the lesions that are granular, that are type 2A, have a lower risk compared to the non-granular lesions or lesions such as the 2A plus 2C non-granular lesions that have a high risk of submucosal invasion with a risk up to 45 to 70%. The granular type lesions can further be subclassified into homogeneous or mixed nodular type lesions, and the non-granular type lesions can be flat, elevated, or pseudo-depressed. The granular lesions have a lower risk for submucosal invasion and the ideal lesions for wide field piecemeal EMR. A detailed exam of the lesions is essential since the non-granular lesions have a higher risk of submucosal and multifocal submucosal invasion and are best suited for resection by ESD. So certain do's and don'ts when you see a large colonic polyp. Look carefully with white light and narrowband imaging, and as I said, look for any signs of submucosal invasion. Take good pictures. Tattoo if the lesion is not obvious, but at least 2 to 3 centimeters away from the lesion, and bring back for an EMR after an informed consent, especially if the patient is there for a screening colonoscopy. That may not be the time that you tackle a large polyp. Only begin the resection if you can finish what you started, because partial resection, tattooing underneath the polyp, or attempting a partial resection all lead to fibrosis and will affect your subsequent chances at a successful complete resection of the polyp. So some pearls for a safe hot snare polypectomy. First thing and the most important thing is a good informed consent discussing the risks, complications, the need for surveillance, and if this is going to be done in an ambulatory setting or versus inpatient. Having a good prep and adequate allotted time to do justice to the lesion, optimize the anticoagulation, perform the procedure under CO2, use a clear cap whenever feasible, locate the polyp and analyze its shape, size, and surface, inspect with white light and narrowband imaging, determine the polyp's mobility and firmness, position the polyp before attempting resection, and use some mucosal injection to evaluate for non-lifting sign, because if you try to inject the polyp and it does not raise, that could be a sign of a submucosal invasion. So the steps involved in a hot snare piecemeal resection is first with inspection, and then injection, and then snare resection of the polyp. And then it is a cycle of the same between injection and resection to resect all visible neoplasia. And then you ablate the resection margins to minimize any risk of polyp recurrence. Retrieving the specimen is as important as resecting it, especially with wide field EMR, because you want to get all the specimen and send it to pathology to help determine what the final pathology results are, as that will determine the timing and the plan for surveillance and next steps in management of that patient. Prophylactic clipping if needed, especially if the lesion is in the proximal part of the colon or patient is going back on anticoagulation. And surveillance. You want to make sure that the work you did is good, and if there is any recurrence, you can manage it early. And then, of course, as I said, if there is any recurrence, then you tackle it and follow the same cycles and make sure that the patient is polyp-free. So we start with the first step of the resection, which is a good inspection. If you can't get a good view, then attach a clear cap at the edge of the scope. Here you can see the polyp is being evaluated under white light and narrowband imaging, and chroma endoscopy was also performed, and no obvious invasive features were noted in the lesion, and the lesion was amenable for endoscopic mucosal resection. Various injectates can be used for piecemeal EMR, from saline to mixture of saline with hyaluronate with methylene blue and diluted epinephrine to the novel premixed lifting agents. Novel solutions do not require mixing and have been shown to require lesser resection pieces and faster procedures. However, they do not contain epinephrine, and cost can also be an issue. Epinephrine used during the in the EMR solution have not been shown to minimize delayed bleeding, but it can help keep the field clear during piecemeal resection. If the polyp is close to the dentate line, you can consider using lidocaine. So after performing a generous submucosal injection in a piecemeal EMR, you don't want to raise all the polyp at once, but as I said earlier, you want to inject and resect as you go. There are a whole host of snares available for resections. I personally prefer the stiff snares, either monofilament or braided. You want to capture the tissue, and as soon as you resect, you want to make sure that the base is clean and then there is no target sign. Here you can see a central depression in the lesion, and this is a typical non-lifting lesion, and if you try to lift it, the central part does not raise, and this lesion came back as adenocarcinoma, and this is the lesion that would not be ideal for a piecemeal or wide field EMR. In terms of which pedal to use during the EMR, no difference has been reported in a multi-center study comparing endocut with forced coagulation with respect to adverse events or recurrence. The main key is to avoid a pure cutting current. The newer electrosurgical units help with blended currents for safer resections. And here you can see the piecemeal resection technique where the polyp is being raised, and you want to create that generous submucosal cushion and as much injectate as it takes to protect the underlying muscularis propria, and then using a braided snare here the polyp is grasped, and you want to take it out in pieces for the wide field large polyps, and check the base, make sure there is no target sign or muscle injury. And then we had to switch to a monofilament snare as the polyp was getting harder to grasp. And sometimes some scarred areas may not come with your traditional methods, and here you can see the underwater EMR technique being used to grasp the polyp. There is literature being reported on polyps completely resected under the underwater wide field EMR technique, which would not require injection. And the coag grasper is used to coagulate a big vessel at the base that was oozing, and a successful resection is performed. After the snare resections, you want to make sure you remove any visible neoplasia. So if there is any residual areas, you could use hot avulsion technique, or use a cold jumbo forceps to remove any residual or fibrotic fragments of a large colonic polyp. After piecemeal EMR, adjuvant ablation of the resection margin, either using APC or snare tip using soft coag at 80 watts or effect of 4, have been shown to help decrease the rate of polyp recurrence at the surveillance exams. Specimen retrieval is as important as resection. You want to retrieve all the specimen pieces and send them to pathology, since this will determine the timing of surveillance and the plan for next steps in the management for the patient. Here you can see we are using a Rothnet to grasp the pieces of a polyp in the cecal base, and the fragments are sent to pathology. Prophylactic clipping post EMR is usually recommended for large lesions or lesions in the proximal colon. However, if the patient is high risk on anticoagulation and the lesion is amenable for endoscopic closure, then you can consider it. Large rectal laterally spreading EMR defects may not render itself for closure. Surveillance after a wide field EMR is very important. Here you can see a large laterally spreading rectal polyp extending to the dentate line. It was almost occupying over 3/4 of the circumference of the rectum and extending at least 10 to 12 centimeters into the rectum. And using the same safe EMR techniques that I discussed earlier, the polyp was successfully resected in a piecemeal manner. And here you can see the resection base. And 6 months post surveillance, you can see a beautiful scar, and there was no evidence of any residual or recurrent polyp. The US Multi-Society Task Force recommends post piecemeal EMR surveillance in 6 months, and then 1 year, and then 3 years after the second exam. So, is wide field resection successful or effective? And studies have shown that it has a success rate of up to 89%. Recurrence can be seen in 13 to 16%. However, eradication of residual adenoma by endoscopic retreatment is seen in over 90% of the patients, with long-term adenoma-free survival reported in about 98% of the patients. Here you can see a polyp with that was tattooed underneath the polyp with significant scarring, and the entire polyp was resected. However, you could see a little bit of recurrence at the surveillance exam, which was successfully treated, and the patient following that had a completely clear resection site. Recent meta-analysis reported EMR and ESD to be safe and effective for colorectal laterally spreading lesions, with over 95% complete resection with both EMR and ESD. However, high R0 resection could be obtained with ESD. And I know there are some great speakers after this talking about ESD for colorectal neoplasia. The recurrence is, of course, higher with EMR, but 88% of those could be managed endoscopically, and the perforation risk does remain high with ESD. Another novel technique for endoscopic resection is the endorotor, which is a novel non-thermal endoscopic mucosal resection device for use in the GI tract for removal of benign neoplastic tissue, especially scarred or recurrent colonic polyps after submucosal injection. It has a rotating blade that resects the tissue and a built-in suction that captures the resected fragments. This is a patient with FAP where we use the endorotor who had recurrence of the polyp in the cuff, and post endorotor you can see a beautiful scar, and majority of the polyp was resected and removed. A procedure is considered safely executed if there are no adverse events. The main thing with wide field EMR is you have to be prepared to manage any complications, whether it's intra-procedure or post-procedure, whether it's bleeding, perforation. Look for the target sign, look at the base after every resection, and make sure you've not breached the muscle. And if you do see the target sign, then you want to zipper close that lesion. Of course, going into every complication is beyond the scope of this talk, but I wanted to put this out there is, just dealing with the polyp and doing the wide field EMR is important, but you have to keep your patient safe and be prepared to manage the complications. So, in summary, you have to risk stratify every polyp. Inspection is important, pre and post polypectomy. Make sure you have the appropriate tools and staff before you take on any wide field EMR. And only start the resection if you think you can finish it. If you feel it's beyond the scope of your practice, consider referring the patient to an expert center. A multidisciplinary approach is key, especially if it is a difficult polyp or if there is a complication. Cognitive thought process is important, and it's as important as technical skills, because just because you can do it doesn't always mean you should. Your patient safety always comes first. Thank you.
Yeah, I'm unmuted. So what I have done at that point is, first of all, I like to use the dedicated cold snares. If you try to use your traditional hot snares to do a bigger cold resection, the chances of getting stuck are higher because they're not designed to have that sharp cutting that the dedicated cold snares are designed for. And nowadays we also have dedicated cold snares which have the ability to attach the cautery. So if you do get stuck, yes, you can attach the cautery and cut it. If you feel like you have a lot of tissue and you are also worried about heat injury, what I do is open up the snare completely and reseat it and take a smaller piece of the polyp. And that will, yes, it will make it into a little more pieces, but if you really want to avoid using cautery and you feel like you've taken too much tissue, that would be one way of doing it.
You can hear the talk. Hello, check.
Any other questions?
Thank you very much. I am Dr. Akram Nadim Ali, Saudi German Hospital, Sharjah. Please, would you please tell us when you send the patient for surgery? Polyps, please.
Yeah, that's a great question. And, to be honest with you, at our institution, a lot of my large polyp referrals actually come from the surgeons where they're like, you tackle it. And if you can't resect it or you feel it's not amenable to endoscopic resection, then, we will feel comfortable taking the patient to surgery. When I first hand send the patients to surgery is when the lesion does have features of submucosal invasion, you know that this is a frank cancer, or the polyp is just so extensive that it is beyond the scope for endoscopic resection. I just majority of the times with good practices, you are able to resect most of them. But as I said, clear invasive features, polyps that are just large and so bulky that you can't even see the proximal end, and you're not sure if you can take it out safely after giving that good submucosal injection. And and it also depends on your surgeons. If you have good backup where you're like, this is the least invasive option for the patient, and I can push the envelope, and you have the good surgical backup, at that point you can try pushing the envelope. But you want to tackle these in close collaboration with your surgeon, where both of you are in sync and on the same page, which lesions you're going to tackle versus the ones you're going to send over to them. And they know that, it's truly when you've tried, and now surgery is the next best step for the patient.